will talk again about the GreenTop guideline number 73, which is about the PPROM management from 24 weeks of gestation. Now, in the previous video, we discussed about the diagnosis of these patients, and now we will talk about the treatment. Now, the treatment is basically dealt with on 4 aspects, that is, what is to be given, why are we giving it, when will we give it, and what is not to be given. It is only on these 4 lines that we will talk about the management. Now, we all know wherever there is any suspicion or scare for an infection, we always give antibiotics. So oral antibiotic, that is erythromycin 250 4 times a day for 10 days from diagnosis, or till labor is established, whichever is earlier, because if the lady already has delivered in before 10 days, then there is no point giving erythromycin for 10 days. So erythromycin 250 QID for 10 days from diagnosis, or earlier if the labor is established before that. If we cannot use erythromycin, we will be given penicillin if erythromycin is not tolerated by the patient. Coamoxiclav is not generally used because it increases the risk of necrotizing enterocolitis in the newborn. Now, this was what are the antibiotics that we will give or we will not give. Why are we giving antibiotics? Why is it that this is so important in the management of PPROM? Now, first and foremost, we know that it definitely reduces infection, so reduces chorioamnionitis and neonatal infections. But apart from reduction of infections, it has also been found to reduce the use of surfactant and oxygen therapy after the delivery of the newborn. So this is another very important advantage of using oral antibiotics. Also, the number of babies that are born within the first 2 and 7 days have been found to be reduced after the use of oral antibiotics. So, early delivery in case of PPROM is also prevented by the use of oral antibiotics. And another very important benefit that we get from the use of this is reduction in abnormal cerebral ultrasound prior to discharge of the baby from the hospital. So these are so many benefits apart from protection from infection, which the oral antibiotic therapy gives us in patients with PPROM. Next important line of management is magnesium sulfate. Now, magnesium sulfate we know is for the neuroprotection. What does that mean? That is, it decreases motor dysfunction as well as cerebral palsy of this cute little newborn. So neuroprotection is another very, very important aspect of the management of PPROM born babies. So it is very, very essential to give it near the time of delivery. That is, when the patient is either in established labor or planned birth is to be happening in the next 24 hours. That is the time, because we all know we give magnesium sulfate for 24 hours. So these 2 conditions, that is when delivery is near, we will give magnesium sulfate to the mother for the neuroprotection of the baby. Now, for neuroprotection with magnesium sulfate, the only gestation that we have to remember is 30 weeks, because it has been found that the greatest benefit of using magnesium sulfate is when it is given before 30 weeks of gestation. So it's important to remember the 30 weeks deadline, that is up to 29 plus 6 weeks. If we can give magnesium sulfate in a patient with PPROM, then the greatest benefit is found to be there by giving magnesium sulfate. But Even for gestations from 30 weeks to 33 plus 6, that is just before 34 weeks, you can consider giving magnesium sulfate. That is not a problem. But offering, for sure giving, offer means for sure giving mag sulf of neuroprotection is must when PPROM has happened up to 29 plus 6, that is just below 30 weeks. So 30 weeks is the deadline for greatest benefit for neuroprotection from magnesium sulfate. So we have done what we are giving, why we are giving, and when we are giving. Next, coming on to antenatal steroids. Now steroids have a lot of myth which rotates around their use, that is chorioamnionitis, neonatal sepsis. It is important to know that there is no increase in chorioamnionitis or neonatal sepsis with the use of the routine course of antenatal steroid injections. Yes, the WBC count definitely rises 24 hours after the administration of antenatal steroid, but it is found to normalize within 3 days after administration of antenatal steroids. Now, why is it so important to give antenatal steroids? It reduces respiratory distress syndrome and intraventricular hemorrhage in the newborn, and very importantly reduces the need for mechanical ventilation. So it is very, very important for the respiratory support, because if the need for mechanical ventilation is reduced, then it's a very, very important benefit. So antenatal steroids give us these 3 very, very important benefits, and initially it was found or thought that it can give protection from necrotizing enterocolitis, but now that idea is discarded. Now, repeat courses is not recommended routinely. Now, the when for antenatal steroid injection is a deadline of 34 weeks. So, if the patient is less than 34 weeks, then definitely you have to offer steroids. Like the deadline was 30 weeks for magnesium sulfate, it is 34 weeks for steroids. Now again, up to 36 weeks, that is 35 plus 6, we can consider antenatal steroids, but it's very, very important to remember the deadline where antenatal steroid is offered as a must and mag sulf is offered as a must. That is 30 weeks for mag sulf and 34 weeks for antenatal steroid. Apart from the antibiotic, magnesium sulfate and antenatal steroid, we have to also give some other supports to the lady with PPROM. That is, the neonatologist should be meeting the lady antenatally as a good practice, so that they can discuss about the baby which is to be born and its management. And whenever the delivery of a baby with PPROM is anticipated, a neonatologist should definitely be informed. You have to give him a call. Now, as far as the IPD and OPD management is concerned about these women, then this aspect has to be individualized from patient to patient, and we have to take into account the markers of delivery latency. That is, how early is the delivery anticipated, and we have to regularly monitor even those patients who are on the OPD observation with their blood tests and clinical assessment, as well as the fetal CTG. It is the fetal assessment. So it is very, very important to monitor even the OPD follow-up patients. Emotional support is important, and it is in the GTG guideline, because these women with PPROM, they require a lot of extra emotional support. And the delivery, the when for PPROM per se, if there are no contraindications, we have to deliver them by 37 weeks. But if there are contraindications, then we have to individualize and think about the timing of delivery, because if there is GBS or anything else which is not allowing the pregnancy to go forward, then we have to deliver. So we will individualize, but if there are no contraindications, we can pull it up to 37 weeks. And recurrence is possible in cases of PPROM. So subsequent pregnancies, they need to be under obstetricians with special interest in preterm birth. Now, the NOTs, that is what is not to be given, is routinely we do not give amnio infusion. This is no more recommended. And tucolysis is not recommended because it increases the risks for chorioamnionitis. So nutshell, this is the management of a lady with PPROM, and this will help us not only solve questions but also manage patients in the clinical setting with utmost efficiency. Thank you.